Welcome to the EKG Guy. My name is Dr. Anthony Kashu. I have this EKG that I want to go over with you, and there's a lot of other things that we have coming out that I want to share with you. So this EKG that we presented here was essentially asking which AV block was present. So on initial inspection, when you look at that EKG, some of the first things that should stand out to you should certainly be that there's, sinus rhythm present, okay? And we're not going to go through all the features here, but sinus, you also notice that there's some sort of AV conduction defect because not all those P waves are followed by QRS complexes. So there's some sort of AV defect, and that was the question here we wanted to assess. The other thing you may notice here is that there's a right bundle branch block pattern. Okay. Now the other main finding is the one we'll focus in on here. So which AV block is present here? Okay, you can pause the video. Why don't you try it yourself? Okay, and when you return, we'll go through this together. And for those of you that have not purchased this yet, this is a free EKG book we're essentially giving away. All you do is pay for the shipping and handling component, but this is our free EKG Foundation Secrets. We only have so many copies left, so grab one if you're interested. So looking back at this EKG, we said there's sinus rhythm present, okay, a right bundle branch block pattern, and some of those P waves that you see here, okay, so you have a P wave here. You can see these P waves in V1. All right, not all of them are followed by QRS complexes. So these first two P waves are, but this one is not. This one is, this one's not, this one is not, okay, and then so forth. So you see that some of them are not followed by subsequent QRS complexes. So in other words, the atrial conduction is not passing through to depolarize the ventricles. So when we look at this, there's a few features you want to look at to help differentiate between AV blocks. And essentially we're going to go, is this AV block 1 or 2, or is this the 2-to-1 AV block? Well, it's certainly not a 2-to-1 AV block because we don't see that here, where you have 2 P waves for every dropped beat, okay? That's sometimes a case where it's hard to differentiate between if it's first degree or second degree. In this case, the one thing you want to look at is the PR interval. So take a look at the PR interval here, where you have a P wave followed by a QRS complexes. So this is your PR interval, okay? And the same thing with the following one, all right? And then you have this P wave here that has a dropped QRS complex, no beat after it. And then we have another P wave followed by QRS, okay, and another P wave. So essentially what you want to look at is those P waves. So imagine here's your P wave, this is your QRS complex, and this is your T wave. We're essentially looking at from beginning of the P wave to the beginning of the QRS complex. So this area here is called the PR interval. And the PR interval consists of the P wave plus the PR segment. Okay, so it essentially includes atrial conduction up until the point of ventricular depolarization. So that's the PR interval. And so what we're doing here when we assess some of these conduction defects at the AV node, if they're delayed, they tend to be prolonged, or there's no conduction through them. So in this case, we have some cases where there's no conduction through to the ventricles, and so we get those dropped beats. Now, in this case, when we look at those PR intervals, we measure them, they're essentially all the same, okay? So where there's conduction so where their AV conduction actually exists, there's normal PR interval. However, where you see those P waves, okay, you simply have those drop beats. So you have these PR intervals that are consistent, and then you have drop beats. And so when you have that sort of thing, this is where you want to think of a second degree AV block, specifically Mobitz type 2. Okay, and so that's the answer here. This is a Mobitz type 2 AV block. Now, what would differentiate from a Mobitz 1 or Wenckebach? Well, remember, that's that longer drop. That's a sign of Wenckebach. Essentially, we're still assessing the PR interval, but you have a PR interval, imagine it like this, in one beat, and then the next beat gets longer, and then maybe you have a dropped beat, okay? But the beat that comes after this one goes back to its normal, or this should be shorter than that one that precedes the dropped beat, okay? So that's one way to tell with Mobitz 1. So essentially here the answer was Mobitz type 2, so sinus, right bundle, second degree AV block, Mobitz 2. Okay. Now I want to talk about a few other features. Now, in terms of second degree AV block Mobitz 1, there's a lot of findings, a lot of things that can cause this. It could be normal in some actually younger patients, healthy. Some could actually have from an inferior MI, and we'll look at some other things. But the one thing you want to keep in mind with this Mobitz type 2, this generally is organic disease, organic heart disease that's contributing to it. So let's look at some of the things here. And what I have here is our coding guide, our ultimate EKG coding breakdown. This one was designed for fellows, so cardiology fellows. So some of this stuff may not be things that you're looking at, but we want to make sure that we have stuff for all of our trainees. So this is more cardiology fellows, but I think you should all be able to grasp this. And this is more of some of our clinical things we want to keep in mind when differentiating Mobitz 1 and Mobitz 2 second degree AV block. So what happens to the QRS complex in these ones? Okay, so in Mobitz 1, you tend to have a narrow QRS complex. Now remember, in adults, narrow means generally 70 to 110 milliseconds. All right, children tend to have sometimes even more narrow, but this one in Mobitz 1 tends to be narrow unless there's an underlying intraventricular conduction defect. Now, in terms of Mobitz 2, what you see are more wide QRS complexes. So this would be 120 milliseconds or greater. And so when we talk about the duration of the QRS complex, imagine here's your QRS. That's from beginning to the end. So what that duration is what we mean here. Now there's some maneuvers that can increase the heart rate as well as AV conduction. Okay, and some of those could be exercise. So if you exercise, you can increase, or atropine can increase conduction of through the AV node as well as the heart rate. And so in cases, if you were to do those maneuvers that increase heart rate or AV conduction, what happens is that in Mobitz type 1, that actually improves the block. Okay, so it gets better. However, what happens in Mobitz type 2, this can worsen it. Okay, and there's a lot of reasons behind this. It really depends on where that defect is taking place in each of them, and some are at different levels in the conduction system. We won't get into that all now. We go into that in the course, but that's essentially the reason why. Now, there's also maneuvers that can decrease the heart rate, decrease AV nodal conduction, such as medications. Adenosine can do that, carotid massage, and in such cases, this would actually worsen. So do the opposite. It would worsen Mobitz 1, and it would actually improve Mobitz 2. Okay, so hopefully that makes sense. And then lastly, I just want to mention some associated factors. Remember that some things associated with Mobitz 1, you want to think of inferior MI, okay, or any AV conduction defect can be associated with that inferior MI. And then Mobitz 2, all right, this is more damage. And so you want to think of anterior MI is certainly one that could be associated with it. And these tend to often have patients that may present with syncope. So they're passing out from that lack of conduction through, and therefore minimizing the amount of output, cardiac output they're getting to the rest and perfusing their organ. So hopefully that makes sense. Again, this EKG, we notice that there's sinus rhythm. There's a right bundle branch block. That's a QR prime pattern that you see in V1. All right, not the typical RSR prime. And notice here in Mobitz type 2, you have an atrial rhythm. In this case, it was a sinus rhythm. And then you have conduction through to the ventricles, so you have the QRS complexes, but then you get those random dropped beats, okay? So no lengthening, no change in the PR interval, and simply a dropped beat, okay? Now, there may be a case where you have prolonged PR interval and a Mobitz type 2. In that case, if you were coding for, say, the cardiology boards, you would code the higher degree of AV block. So even if the PR interval was prolonged and you had a Mobitz type 2 pattern, you would code Mobitz type 2 because that's the higher degree. And that's essentially how we do it clinically. So hopefully that makes sense. Again, just to recap all of our things here. Again, QRS Mobitz 1 tends to be narrow. Mobitz 2 wide, okay, depending on the degree and the level of where that defect occurs. Things that increased heart rate or AV nodal conduction, okay, maneuvers, we said can improve Mobitz 1 but tend to worsen Mobitz 2. Things that decrease maneuvers, that decrease the heart rate or AV conduction, whether it's carotid sinus massage or adenosine, can worsen Mobitz 2 but improve Mobitz type 2. And then lastly, some associated things you should think about with Mobitz 1, inferior MI, and then Mobitz 2, more of a bigger territory, anterior MI, that tends to be affected, and also the associated syncope, more common with Mobitz 2 than Mobitz 1. All right, so hopefully that makes sense. Again, if you haven't, grab one of our books, okay? If you're a cardiology fellow, we have our coding breakdown available here as well, okay? If you're also looking for another book, we have our pacemaker book, okay? Really designed to take you from a beginner to advanced level. We have a lot of different books available, okay? So here's one. This is the pacemaker book. We have another. The most popular course we have is the Ultimate EKG Breakdown, designed for all levels of trainees, really from beginner to advanced. This is the most popular book that we're actually out of stock now and hopefully have this back in. This is the second edition, essentially a textbook of EKGs. Okay, all of our stuff includes videos, questions, practice, and we're so grateful for all the programs, institutions that continue to support this mission to improve ECG competency among medical professionals. Thank you so much. Stay tuned for a lot of exciting updates that we have with our partners that are coming on board, and all the content we'll be releasing. I think you'll start to love it. Well, thank you so much. Have a wonderful day.